So our last panel of today looks ahead to the issues that we'll face as a country and that the whole of humanity is going to face if and when we do have developed and tested and approved one or more safe and effective COVID vaccines. I know we all yearn for the day when we can put this pandemic behind us, but I think many, including many of the people who you've heard from today, and I would include myself, would argue that it really is highly unlikely that we're going to get there without vaccines and therapeutics. But once we have them, who will be immunized first? How will national and global allocation be adjudicated? How will health equity and social justice issues affect vaccine allocation, particularly in that critical phase? Goes back early to the beginning of the day with Monsef's comments, when we have effective products, but supplies may be limited. And to help us think through these enormously challenging issues, we're really very fortunate indeed to have two distinguished co-chairs for this last discussion. Dr. Helene Gayle is one of the most prominent women in American science, and she served as co-chair for the recent National Academies Committee report on equitable allocation of vaccine for the novel coronavirus that several people through the day have alluded to. Dr. Gayle will be joined by the great bioethicist Ruth Faden, who's the director emerita of the Berman Bioethics Institute here at Johns Hopkins. And they will be joined on the panel by Dr. Nancy Bennett, who is a past chair of the U.S. Advisory Committee on Immunization Practices, the ACIP, and is also professor of medicine at the University of Rochester. Dr. Chris Murray, the director of the Institute for Health Metrics at the University of Washington. And he and his group have really been leading much of the modeling work that's been so influential in understanding COVID-19. And also joined by Bill Moss, who's the executive director of our International Vaccine Access Center at the Bloomberg School, and really has been a leader in thinking about international vaccine access research. So Helene and Ruth, the session is yours.
Thanks so much, Chris, and it's wonderful to be with Ruth and the fellow panelists. And I think we'll have a lively discussion. Maybe I'll just start out by giving a little bit of the highlights of the report that just came out on Friday. It is a 237-page report, so in case you all don't get to read everything, it has lots of appendices as well. I'll just maybe give some of the highlights. And I'll say, this was a report that the CDC and the NIH asked the National Academies of Science, Engineering, and Medicine to do, with the idea that we didn't know when a vaccine was going to be available, but as you said, that it is likely that there will be scarcity, and it would be important to have a framework to guide that. So, we worked over the summer quickly to put together this framework using a set of kind of accepted overarching principles, ethical and procedural principles like fairness, like equal regard, like particularly for this mitigation of health inequities and maximum benefit and other things that we thought were particularly important foundational principles. And we also put together a risk framework based on risk of acquiring or transmitting the infection, risk of serious illness and death, and then risk of negative impact to society. And really took as our overarching goal, how could we come up with a framework that reduced severe morbidity and mortality, negative societal impact through the transmission of SARS-CoV-2. So that was kind of what went into it. And, I think most people know we came out with a 4-phase framework, really trying to optimize that the risk of acquiring illness or severe societal impact, and came up with 4 phases, as opposed to tiers, where thinking of tiers as more hierarchical, who should always have it first. We really looked at this more as a temporal issue of who should have it first, and then next, and then on down the line, with those at greatest risk for acquiring it, people who are on the front lines, healthcare workers, frontline workers, those who have the greatest risk of severe disease, of people of all ages who have the conditions that CDC has said make one most vulnerable for poor outcomes, and then any older person living in congregate settings. So that was where we started as the highest priority first phase, and then worked on down that kind of risk hierarchy.
I'm about to go on.
Worked on down that risk hierarchy.
Please.
With the last phase, the last phase being all adults living in the United States, because ultimately we felt all people living in the United States, because ultimately we felt this is a vaccine that when available, anyone should have access to it. And so the phases continue on from highest risk to ultimately the whole population, anyone residing in the United States. Across all of those phases, we also looked at the issue of equity, because as everybody knows, this is a pandemic that has disproportionately impacted people of color and people who have social vulnerability. So across all 4 of those phases, we said that geographic preference should be given to areas who are high on the social vulnerability index or some other index that kind of takes into consideration kind of the social determinants of health and the things that have made populations most vulnerable, particular populations of color. We came out with, at the end, 7 recommendations. The first one that these recommendations and our framework be adopted at the national level and by the state, tribal, territorial, and local health officials that will ultimately have responsibility for implementing this. We also had 2 recommendations that focused on implementation, with a big focus on making sure that existing systems get strengthened as opposed to creating new systems, and that there be no out-of-pocket costs for anyone, so that costs should not be a barrier. We also had 3 recommendations that focused particularly on the issue of vaccine hesitancy, and were recommendations around developing a national campaign, developing a database about risk and vaccine promotion and acceptance, and then making sure that there is a strong link to community-based organizations and a information campaign that particularly took into consideration populations where hesitancy was great and where there's a great risk of not having access to vaccine. And then finally, we had a recommendation focused on global allocation and making sure that the United States lived up to its global commitment, global obligation to be able to also think about allocation of vaccine, some portion of vaccine to the rest of the world, and recognizing our global obligation for fairness and justice and equity as we think in the global context. So that in a nutshell is what we came up with, and we may get into more of that, but I'll now turn it over to Ruth, who has also been involved in an allocation framework on the global stage, to talk a little bit about that, and then we'll go to our panelists.
Thank you, Helene, and thank you, Chris, for inviting us and our panelists to speak to this incredibly important issue. I know time is short, but it does seem important to do just a few framing things, and I know that Bill Moss will follow up with some more. So the concept of equity at the global level is orders of magnitude more complicated than within country equity, as difficult as the latter is. And I do want to say, a huge shout out to Helene and her colleagues. It's a phenomenal report. And I have to say that we, those of us who are thinking about this, and I know Helene is always, at the global level, we're thrilled to see the recommendation that the US live up to some, at least minimal expectation of obligation at the global level. The allocation questions within countries outside of wealthy countries, when you get to low and middle income countries, as everyone here I know appreciates, are constrained by what happens at the level of global equity. So as a concrete way of making this plain, the NASEM document goes to a 4th phase with the expectation that there will be a time when there will be vaccine for everyone in the US who wants to be vaccinated. That's an expectation that many countries in the world just cannot realistically have. And that is the sort of backdrop against which global equity issues are raised. The principal institution that has been set up to deal with global equity issues is the COVAX facility. And I believe that Bill is going to speak to what that is. I won't go into that now, except to say that the US is not currently a member or participant in the COVAX facility. It is understandable that countries recognize and live up to obligations to secure sufficient vaccine for their own populations first, but that obligation does not absolve countries of obligations to at least not stand in the way of low and middle income countries having access, and more affirmatively to people living everywhere, people living in countries who cannot, without assistance, be provided COVID-19 vaccine. So it's a matter of global equity that high-income countries contribute to the global equity goal, but it's also a matter of national self-interest. We all know the public health concerns that infectious threats to health know no borders, that for all of us is canonical. And there are also clearly questions of the recovery of national economies, stable global supply chains and global markets, and the regularizing of international travel will all depend on some kind of at least de minimis equitable access of COVID-19 vaccines around the world. The WHO is involved in several processes to address the values and equity questions in COVID-19 vaccine allocation between countries and prioritization within countries. So very quickly, it's a bit of a kind of a word salad, but there is the COVAX Access and Allocation Framework that has been published, and its focus is on allocation between countries of vaccine through the COVAX facility. Then at the WHO level for prioritization within countries, there is the SAGE Values Framework that was released in September. That framework addresses both allocation between countries and prioritization within countries, and includes in that framework many of the same principles as exist and were articulated in the NASEM report. So there is kind of a global consensus emerging around the relevant values that should matter. And then finally, just this morning, we presented to a group at WHO what is now the SAGE roadmap for prioritizing uses of COVID-19 vaccines in the context of limited supply. This was just discussed for the first time publicly this morning, but it is a recommendation for prioritization of uses with priority groups for 3 different epi-settings and 3 different stages of vaccine supply within each epi-setting. So I'll stop there. I don't know if there'll be time for discussion. There probably won't, because we have such wonderful participants on the panel and we need to hear from them as well. So over to you, Helene, to introduce our first colleague.
Great, thanks so much. And I won't give any long introductions. People have folks' bios, and I will turn it over first to Dr. Bennett, who is the director, well, Chris mentioned, but Director, Center for Community Health and Prevention, University of Rochester School of Medicine and Dentistry, to talk about your experience with vaccine allocation and frameworks.
Thank you so much. It's a pleasure to be with you today. I thought I'd give a little background first about the Advisory Committee on Immunization Practices. It was established in 1964 by the Surgeon General to provide guidance to the Director of the Centers for Disease Control on the most effective vaccines and biologic products to prevent infectious diseases. It is an independent committee of immunization experts and a consumer advocate drawn from academia and public health. The committee meets in public and maintains transparency in its deliberations. The ACIP reviews the quality of evidence regarding the benefits and harms of a vaccine. This is analogous to the procedure that's done by the FDA and its advisory committee that you heard referred to earlier, VRPAC. The ACIP, though, goes farther. They use evidence to recommendations framework to consider the public health burden and importance of a disease, the values related to the use of a vaccine, resource requirements, and feasibility. This second part of the process is really very critical to ensuring that the right people get the right vaccine at the right time. In the case of COVID, this is complicated. The committee must weigh potentially competing goals, looking at safety and efficacy, of course, as the most important aspect, but then how are we going to best prevent transmission, severe disease, death? How do we minimize disruption to society and to the economy? And how do we ensure equity in vaccine allocation and distribution? The ACIP COVID-19 vaccine work group meets weekly and has been reporting to extra special meetings of the ACIP all summer. The work group and a vaccine safety technical subgroup are independently reviewing and presenting to the full committee safety data from phase 1 and 2 trials. When phase 3 trials become available, the work group will then review efficacy data and also present that to the full committee. When and if the FDA licenses or authorizes use of a vaccine, the ACIP will convene an emergency meeting to consider and vote on guidance regarding the prioritization and use of vaccine in specific groups. ACIP then forwards the recommendations to the Center for Disease Control Director, and they are approved prior to being published and becoming policy. Of note, ACIP recommendations mandate coverage by the Vaccines for Children program and by most commercial insurers. This is an important step in ensuring equity access to vaccines. Until data become available from the phase 3 trials, it's hard to know what the balance, the benefit-risk balance, will be of different vaccines in different populations. It's also uncertain which groups will be included in licensure or authorization. However, the committee has proposed a draft vaccine allocation framework similar to the National Academy framework, focused on equity and the maintenance of essential services, including healthcare. This framework will be the foundation on which the more specific recommendations based on safety and efficacy will be built. The FDA conditions of use will include to whom the vaccine may be given, while the ACIP will recommend to whom it should be given. The ACIP views its independent review and recommendations as critical to the safe, equitable, and efficient allocation and distribution of COVID-19 vaccine. While national guidance will be essential, the committee also acknowledges the importance of local flexibility and implementation. Finally, the ACIP will continue to monitor COVID-19 vaccine program for safety and effectiveness going forward. During this time of uncertainty and widespread skepticism of governmental agencies and policies, the independent and transparent deliberations of the ACIP are more critical than ever in restoring confidence in COVID-19 vaccine. It is essential that the committee's carefully considered recommendations form the basis of national policy for vaccine allocation and distribution. Thank you.
Great. Thanks so much. And we'll probably get into some questions if we have time, but I think that was a very useful framework of the role of the ACIP. Next, we'll turn it over to Dr. Murray. Dr. Chris Murray is the director of the Institute for Health Metrics, Evaluation, and chair of the Department of Health Metrics at the University of Washington. And I believe will be talking to us about how scenarios and actually figure into this as we think about the distribution and allocation of resource, and something you've done that has been so helpful in the modeling realm. So, Dr. Murray.
Thanks, Helene. So first as context, we at IHME have been modeling the pandemic since the 1st of March and continue to try to produce updates of the trajectory of the pandemic, both for the US and for all countries in the world on a weekly basis. We are forecasting, because we think COVID is about as seasonal as pneumonia on average, and that's the statistical result. So we're forecasting quite a substantial winter surge in the US and across the Northern Hemisphere. And it's become, many people have started to ask us in our base case or our reference scenario, that's what we think is most likely going to happen. How are we capturing the potential rollout of vaccines? So right now, we're rather intensively trying to incorporate vaccines or the prospect of vaccines into our forecast framework. And our public release runs about 4 months into the future, and then we also make much longer term forecasts for other policy users. So the issues that we've been trying to look at is, first of all, the one that many have discussed is supply. The best estimates from both the manufacturers, COVAX and others, is that even by the end of 2021, at best, 20% of the world would be vaccinated, more likely a smaller number. And so then it really becomes an important issue as to who gets vaccinated. Second issue that goes into our pragmatic modeling of what the impact of vaccines is hesitancy. We know from the Facebook symptom survey that is deployed worldwide that hesitancy ranges from only 30% in some countries willing to take the vaccine to 85%. The US runs around about 60%. So that certainly factors into the sort of potential pool of people who could be vaccinated. Then there's the obvious issue of efficacy, which the trials will tell us, and we'll have to, make a stab at it until the trials come out. The one that doesn't, I think, feed into some of the discussion so far is, of course, what's been the cumulative infection rate already. Because the impact of vaccination, if very few people are vaccinated, then it's really all about who you vaccinate. If you are getting close to herd immunity, let's say Manaus in Amazonas in Brazil, then the impact of vaccination may be enough, a small amount of vaccine may be enough to push a community up to the level of herd immunity. So that becomes a factor in places like Ecuador or Peru or Mexico City that are over 40% already infected. That cumulative infection factor becomes an issue. And then the one that is the most important is this issue of who gets vaccinated. And as you nicely said at the beginning, there's this trade-off between some fairness principles and maximum benefit. And we're trying to forecast what's likely to happen. And I think between countries, it's, the drive will be towards a per capita formula for allocation, because anything else really is quite challenging. So that's sort of our guess as to what might happen, despite very complex issues that could actually be used. And then within countries, the at-risk groups, as you discussed, it's quite controversial right now, as a last comment, with some of the models that have come out as to whether if you are worried about trying to have the greatest benefit, would you be better off vaccinating those who are most likely to die or most likely to transmit? And so that is a bit of a contentious topic, and perhaps one that some of the modeling will give different answers and will make it even more challenging for policymakers to navigate that terrain. So I'll stop there.
Great, thanks. We'll move on to our last speaker, Dr. William Moss, who's Executive Director, International Vaccine Access Center at Johns Hopkins Bloomberg School of Public Health.
Thank you, Helene. And what I'd like to do is very briefly make a case that preserving the scientific integrity of getting to a COVID-19 vaccine is really critical to achieving global equity for vaccination. And in turn, achieving global equity is critical to the integrity of the whole process. I'm very briefly going to touch on 4 topics. The first is the importance of ensuring equitable access for COVID-19 vaccines. The second is the mechanism to do that through COVAX, as Ruth mentioned. The third is some current thinking about how to achieve this. And this builds on work that Ruth and Helene have led. And then very briefly, some of the challenges going forward. But this is obviously a global pandemic, and we need a global response. And there there are a number of reasons why we in the United States need to ensure equitable access to COVID-19 vaccines. First, it's a public health imperative. We cannot control this pandemic unless we control it everywhere. And so the whole world needs access to COVID-19 vaccines. Second, it's a moral imperative that we contribute to the good of humanity by this achieving equitable access to COVID-19 vaccines. More selfishly, it's an economic imperative, as Ruth alluded to. Our economies will not recover until this pandemic is at least mitigated in much of the world. It's perhaps even a political imperative. We're seeing the vaccine perhaps used for political purposes reminiscent of the Cold War era. And lastly, from a very selfish point of view, participating in the COVAX, and I'll describe that briefly, will help ensure people in the United States safe and effective access to a vaccine. So what is the mechanism for achieving global equity? Ruth mentioned COVAX. So COVAX is a part of a broader initiative, global initiative called Access to COVID-19 Tools Accelerator, or the ACT Accelerator. This addresses vaccines, therapeutics, and diagnostics. So COVAX is what's called the vaccine pillar of the ACT Accelerator. There are three groups, large groups that lead COVAX: Gavi, the Vaccine Alliance, which leads on procurement and delivery, the Coalition for Epidemic Preparedness Innovations, or CEPI, that leads on development and manufacturing, and the World Health Organization that leads on policy and allocation. But this is really a large global effort that includes governments, global health organizations, manufacturers, scientists, private sector, civil society. And the goal is to have 2 billion doses of one or more COVID-19 vaccines by the end of 2021. And COVAX is supporting 9 CEPI supported vaccines. So there are 9 vaccines kind of within this COVAX facility, and the goal is to have 2 billion doses. What this does is leverage the buying power of multiple economies or countries that really ensures or guarantees vaccine is available not only to the higher income countries that are self-financing and can pay for the vaccine, but very critically to lower and middle income countries that are less able to purchase vaccines. Currently, there are 76 higher income self-financing economies in COVAX, 92 lower and middle income countries, thus 168 economies that are part of this global effort to ensure equitable access to vaccines. That's covering 2/3 of the world's population. So in terms of approaches to thinking about equitable access, and Ruth Faden has been critically involved in these, the work led by Helene, Gayle, critical to this as well. As Ruth said, there's been a values framework that's laid out. This is under the World Health Organization, lays out 6 core principles to guide allocation of a vaccine: human well-being, global equity, reciprocity, equal respect, national equity, and legitimacy. There's also, as Ruth mentioned, the COVAX facility allocation mechanism. This is the proposal for getting vaccines to all countries of the world. It's done in 2 phases, with allocation of vaccines proportional to the population size, targeting tier 1 target groups, those highest risk groups. Initially 3% of the population, but expanding out to 20% of the population. And then a phase 2 that's a weighted allocation based on a risk assessment, which countries need the vaccine the most, that'll take the coverage above 20%. There's also, as Ruth mentioned, and she just presented it this morning at the World Health Organization Strategic Advisory Group of Experts meeting, a planning tool that's a prioritization roadmap for within-country allocation. And then, as Helene mentioned, the National Academies of Sciences, Engineering, and Medicine, their framework for equitable allocation of COVID-19 vaccine, their last chapter, chapter 8, is ensuring equity globally of a COVID-19 vaccine. And And Helene or Ruth alluded to the fact that on September 2nd of 2020, the White House announced that it would opt out of the COVAX facility. So the United States government or the United States is not participating in this global effort. And the National Academies framework specifically recommends that the United States opt into the COVAX facility, that we deploy a proportion, for example, 10% of the US vaccine supply for global allocation, and critically that we re-engage and support the World Health Organization in their efforts. So the challenges going forward, as we've heard from all the panelists, there's going to be a limited vaccine supply early on, and that's going to make it very difficult to achieve equitable allocation of a vaccine. And that's why we need these processes and need to be thinking about this now. There are going to be, or the other challenge is our nationalistic approaches to vaccine allocation, where countries just focus on their own populations. And there is, I understand the motivation for that, but there needs to be a broader view, and we need to achieve more equitable global allocation in order to really get control of this pandemic. Thank you.
And the challenge of being the last panel is that to keep things on time, we have to cut this short. We would love to have had more time for discussion and question and answer from our three incredibly wise, insightful panelists. But unfortunately, we've got to close this session off. So I will just turn it over to my co-chair to end with any words, and then we'll turn it back to Chris.
I think my words have got to disappear as well because of the concern about time, which we totally appreciate. And just want to echo Helene and extending apologies to our panelists. We had believe it or not, we had great questions for you. We just, we'll have to ask them of you offline, and thank you for participating.